once the program will be over, now I will send you the YouTube link, Jinal. So you can.
Yes, ma'am.
Yeah.
Sure.
Yeah.
Good evening, participants, and good evening, faculty members. Thank you for joining Shield Connect. Today, we are back with our series Icons in Conversation with Dr. Ritu. And today's topic is whose responsibility is it to breastfeed a baby? And today, the icon for the day is Dr. Zinal Unadkar Shah. And before we start with the session, let me introduce Dr. Ritu, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, MR, COG, obstetrician and gynecologist in IVF, and founder and CEO of 360 Degrees Healthcare Studio. And also, ma'am is consultant in Inamdar Multi-Speciality Hospital, Pune. And ma'am is also infertility test tube baby specialist and has done NUHS from Singapore. Ma'am is co-founder of MAAM, board member of WSCG. Now, let me introduce our icon of the day, Dr. Zinal Shah. Ma'am has done MBBS, DCH, IBCLC. Ma'am is pediatrician, lactation consultant, working in Hiranandani Hospital, Powai. And ma'am is India coordinator of IBCLC and BPNI Maharashtra. Ma'am is also connected with Hinduja Healthcare in Khar, Criticare Hospital, Mother Care's Clinic from Mumbai. So we welcome you, ma'am, on our platform for today's talk show. And I will hand over the session to Dr. Ritu. Thank you so much, ma'am.
Yeah. Thank you, Nishan. So, friends, as all of you are aware, this series is coming on every Thursday. We are here with one of the icon, and today's icon is very, very special with us. This time in this our series, we are having a pediatrician, a very dear friend of mine, Dr. Jinal Shah is with us. We all gynecologists have a lot of questions in our mind related to the newborn. Whenever we meet and discuss कि हमको इसके लिए क्या करना चाहिए था, क्या नहीं करना चाहिए था. Actually, friends, let me disclose here. I met the Jinal in one conference only a month back. I was highly impressed by her talk. So I thought in this series, where all the delegates are joining all across the geography, why not we invite the fantastic speaker like Dr. Jinal? Today she is going to discuss with us that breastfeeding is whose responsibility, whether it is ours or the pediatrician or the mom or our joint responsibility. So the friends, as all of you are aware, the program is going live on the YouTube. So you all are welcome to put your questions, and we can take the advantage by increasing our knowledge by having the Dr. Jinal Shah with us. So Dr. Jinal, a very, very warm welcome to the show. So now I am handing over the dais to you. Please enlighten us about this special topic which you have chosen.
Yes, thank you very much, Dr. Ritu, and a very warm good evening to everybody who's listening to me. And thank you, Nishant, for a lovely introduction. And I'm really, really excited to talk today because I think I'm very passionate about breastfeeding. So I am a gold medalist and a university topper through and through from KEM. But still, I decided in my regular pediatric practice, I realized that lactation is not getting that much importance and a lot of mummies are not able to breastfeed. So I became a lactation consultant. And in fact, I'm one of the first lactation consultants of India, where people did not even know what lactation consultancy is all about. So for people who don't know, there is a degree by the name of IBCLC. So I think now a lot of people in Pune have become lactation consultants, and that awareness has started coming in with a lot of, enthusiastic doctors like me who are working. Even ma'am is very enthusiastic for breastfeeding. But I feel that we all need to have a common agenda and a common goal. Now, in whatever practice I have been doing and we've been coming across patients, what I'm realizing is that the initiation rate in majority of the hospitals all across India is extremely poor. So in the latest NFHS data, it has been shown that the initiation rate is only 41%. That means only 41% of babies have been put to breast in the first 1 hour of birth. And either the babies have been separated from the mother, been handed over to the pediatrician, or the mother is kept in the recovery, or probably the mother has not been given the baby only. Half of the time it is like a mismatch which we are seeing in all hospitals. So I really felt that this is something which is a gap which needs to be covered, because I think we are not somewhere going the right way which we should be. Now, it is very surprising, Dr. Ritu, and I really feel that in our curriculum as MBBS or even MD or pediatrics, or even when you did gynecology, breastfeeding is never covered.
True.
There is nothing. There's one or two pages on breastfeeding. That's all about it. Okay. Nothing has been taught. Even in our residency days, no importance has been given to the fact that, and I still remember even in our residency days, I never sat and helped a mother, even when I was posted in my OBGY unit. Okay, haan, chalo, I will help you breastfeed. I mean, that was never given importance to, and we were never taught about it. So I feel that in India, any which ways, mothers are quite self-motivated to breastfeed, So we do have a lot of mothers, especially when we work in a municipal hospital or when you are working in a little lower socioeconomic status. Those mothers don't know what formula feeds are. Those mothers don't know कि हम कुछ और दे सकते हैं. So उनके लिए तो खाली बच्चे को उठा के breast पे लगाना है. Now, if you go back to maybe many years back, probably our dadis who delivered at home, there were dais who used to deliver. That moment of time, obstetricians never existed, kind of, था ही नहीं वो concept कि हम hospital में जाके delivery करेंगे. घर में deliveries होती थी. And then the baby, as soon as the baby was born, they used to not cut the placenta, and the baby was picked up and put onto the breast, right? Because they used to not cut the cord, sorry, because what happens is, that is how a baby is to be kept. The mother's chest is a habitat for the baby. 9 months, the baby was in the mother's womb, and the baby was in that amniotic fluid and being well taken care of. Now, when the baby is outside, the baby still needs to be there to feel the mother's skin, the mother's warmth, to listen to the mother's heartbeat, and doesn't feel lost and secure. Now, what we do is we cut the umbilical cord. The baby is handed over to the pediatrician, who takes the baby in another room. Then the baby is crying and howling. The baby doesn't know where the baby is. So psychologically and emotionally, the baby is not able to acclimatize to the new environment which the baby is in. So I think this is something which we all need to understand, that the mother's chest is the baby's habitat. And baby feels very secure and very calm when the baby comes onto the mother's breast. So I think we need to start practicing delayed cord clamping, where we pick up the baby and we put the baby onto the breast. Now, what happens is, when you picked up the baby and put the baby onto the breast, the baby, because it is new to this world, it is very alert. Okay, the baby looks around. The baby is very, 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 excited that मैं कहाँ आ गया. So the baby, all the 5 senses, the baby crawls and finds its way to the breast, and the baby actually goes and latches onto the breast on its own without anything. Now, this is such a beautiful thing which is called breast crawl, which we all can practice even in our busy practices. And we can pick up the baby and we can put the baby on the breast, okay, or on the mother's chest, and the baby just goes and finds its way. Now, because the baby is very active and alert, the baby has already learned to latch on. And when the baby is on the mother, the gravity also comes into action, and all the primitive reflexes of the baby start, getting activated, and the baby beautifully latches. And also from the obstetrician point of view, what happens is, because the baby has latched, the placenta delivery will be faster, the uterus will contract faster, the maternal blood loss will be lesser, and the mother will be distracted. So she will not scream with the pain, कि मुझे दुख रहा है doctor, ये हो रहा है, वो हो रहा है. There are a lot of things which goes on in the labor room. There is a lot of screaming, paining, a lot of things which go on. We all know how the labor room scenarios are. So this really helps in calming down the mother, because oxytocin goes high. The moment oxytocin goes high, what happens is the mother calms down and she feels happy. She feels happy to hold her baby, and she feels happy that, I'm connected to my baby. And obviously, seeing a happy baby, 9 months she has waited for this baby. So this is a very beautiful moment. Now, what probably I have also realized is that our labor room team is not mother friendly. Most of the staff is screaming at them, "Arey zor kar, arey zor kar." There is nothing which is being given to them. Sometimes, there is no music going on. There is not, like, I feel that a labor room environment should be made like a beautiful candlelight dinner environment, where the mother is, having beautiful lights, some beautiful music, where her companion of her choice will be allowed, whether it is her mother, whether it is a friend, sister, husband, whomsoever she wants. She can have some kind of a green tea, nice lemon drinks. She can have something which gives her happiness and which gives her that ability to actually deliver. Now, I had gone to Penang for a conference, and what I saw over there, there was a very beautiful board on outside that what analgesia the mother wants. Okay, so there is one pharmacological and non-pharmacological.
Right.
So pharmacological is obviously, you do epidural anesthesia, you give sedation or whatever. Non-pharmacological mein, one was companion of your choice. Second was you want any warm drink. Third, you want any massage. Okay, then fourth, you want any music. Okay, and fifth was you want to meditate. You want to do deep breathing, or you want to exercise companion who can come and help you, squat in a better position. Now, this is something which is so beautiful, that mothers are given that respect, that you deliver the way you want. You can sit in whichever position you want. So there are a lot of things which probably goes on in a labor room, where a mother is on the center of the table, where the whole team is surrounding her, and she feels so awkward कि सब लोग मुझे क्यों देख रहे हैं और सब लोग मेरे को इतना गुस्सा क्यों कर रहे हैं. So I feel somewhere, when the environment becomes mother friendly, okay, in the labor room, okay, the delivery process eases out so much, and you don't land up getting a instrumental or a cesarean section. And in that, the mother is in such a happy mode that she would love to breastfeed. So I feel the first step to breastfeeding is the state of the mother.
Great.
Where the mother is coming from, how much stressed she is, how supported she is feeling, how comfortable she is feeling. So I think if this changes, probably the breastfeeding initiation rates will also change. Okay. Now, most of the time, what I have seen, ma'am, I mean, I'm not, saying about you or anybody, but most of the obstetricians care for the mother for 9 months, right? 9 महीना, she will listen to you. आप बोलोगे ये मत खाना तो वो नहीं खाएगी. आप बोलोगे ये है इतना walk करना, वो करेगी. She will follow to the T what everything the obstetrician says. So if the obstetrician only tells her about breastfeeding in her pregnancy during the antenatal meetings, she knows what she is supposed to do. So then she knows that I'm supposed to do initiation of breastfeeding. I'm supposed to pick up my baby and put my baby to rest. So she knows this is my next step. Like how the next step is after the baby placenta has to deliver. Then you have to do a power channel examination to see for the blood clots. So we have a protocol. So why breastfeeding does not come into the protocol? Okay. So somewhere breastfeeding also should be into a protocol where you tell her about it. And I think most of the mothers know, they don't know the pediatrician, because pediatrician का वो बोलते हैं ना special appearance रहता है हमेशा. वो भाग के आते हैं, okay, वो late ही होते हैं आधे से ज़्यादा time, and they have to run because या तो OPD छोड़ के आए हैं या तो दूसरे call में जाना है. Okay, so half of the time the pediatricians are running. Okay, I mean we are like that only because we go to so many maternity homes and hospitals. We are not that full timers where चलो आराम से बैठे हैं, 1 घंटा patient से बात करेंगे, वो नहीं होता है. So what happens in that scenario is that they don't give importance to breastfeeding. I agree that even we are at fault. Okay, हम नहीं देते हैं because हमको जाना है दूसरे patients के पास, because we have crying babies waiting in the OPD. Now the pediatrician will probably just have a look at the baby, will say हाँ ठीक है sister, आप formula feed दे दो, आप injection vitamin K दे देना, बच्चे का वजन कर लेना, और या तो मैं vitamin K देके 2 मिनट में relative से बात करके face presentation करके जाता हूँ. So that is somewhere that probably obstetrician gets busy with the delivery, pediatrician gets busy with the other commitments. The staff nurse which is working in the labor room will have 100 other things to do. The cleaning करना है, ये करना है, injection देना है, hospital इतना busy है, I have to run. So there is nobody actually who's taking a onus and responsibility of making the baby latch. The initiation doesn't happen only. And the baby is actually given by the maushi or the sister a formula feed. कि अच्छा pediatrician ने बोला है अभी तो formula देना है तो मैं formula दे दूंगा. The moment formula feed is given to the baby, what happens is it's like baby's stomach is completely full. The stomach capacity of a newborn baby is only up to 5 ml, a tennis ball size. Now imagine in that small stomach capacity, you have given 15, 20, 30 ml of the formula, which is very, very rich in lactose and fats. The baby feels very heavy and the baby goes to sleep because any which way the baby is tired with the labor process. Now, in this scenario, when the mother is ready to breastfeed the baby after 2 hours, 3 hours, she tries to pick up the baby and put the baby to breast. The baby just doesn't latch on because the baby's stomach is full. If my stomach is full and you give the best of the foods to me, what will I say? मेरे को भूख नहीं है. I don't want to eat. And this is what happens with the baby. And the mother goes into a negative psychology that, oh, my baby doesn't like my breast, or I don't have enough milk, or probably I'm not a good mother, and she goes into a guilt mode. And that is where breastfeeding failure starts. So this first 4 hours are the most important to decide whether that mother is going to happily breastfeed and the baby is going to beautifully latch, or it is going to be a struggle. So in my experience of last 20 years, I have seen that the moment baby latches within the first 1 hour or maximum within the first 4 hours, and if the first feed given to the baby is mother's milk, there is no problem with the supply. There is no problem with the initiation, with the expression, or with the feeding of the baby, because the baby has learned how to latch. So that learning of latch, we don't allow the baby to do. मतलब हम उठा के बच्चे को रखते ही नहीं है. So I think that is something which is, as ma'am was saying, that whose responsibility is it? Honestly, I feel it is a responsibility of the patient, because if patient says कि मुझे breastfeeding करना है, okay, doctor, please don't give formula. You know, in most of the countries, if a formula feed is given to the baby without the consent of the mothers, that doctor can be sued. In India, we are not sued, but the parents just blindly follow us, right? तो हम बोलेंगे तो वो लोग कर लेंगे. But I feel it is a responsibility to educate the mothers, to educate the family. Okay, there we all play a very important role, because in the antenatal session, whenever we have, you tell them that you have to do breast crawl or you have to do initiation within the first 1 hour. I have had patients who have attended my antenatal sessions and who have fought with the obstetricians or fought with the pediatricians in the labor room. मतलब you make them the warriors. That's what I feel. मतलब उनको ही तुम warrior बना दो कि हम मुझे मेरे बच्चे को मेरा दूध पिलाना है. Then nothing comes in the way. So I think the right education given to the mothers by obstetricians and by maybe us, who we say that yes, it is important that you do right initiation and you give the baby only mother's milk. Now we all know why mother's milk is important, right? So I'm not going to go into the details of that, but there have been studies which have proved again that 1 in 2 of the healthcare workers who are caring for the mother and the baby are unaware about breastfeeding. तो हमको ही नहीं पता है क्या करना है, तो how do you expect the mother to know? So we need to educate them in a way that they know what is right and what is wrong, and then help them take an informed decision. The way you discuss about the labor, I'm sure all of you all sit and आप discuss करोगे कि normal delivery में ये होता है, epidural में ये होता है, cesarean में ये होता है. So even breastfeeding should be a part of her education. When you discuss birthing protocols, when you discuss with her कि अच्छा ये भी possibility है, ये भी possibility है, we should discuss that breastfeeding is a part of it. And I feel, no, if all of us train 1 staff or 2 staff in our nursing home or hospital, they do it for us. मतलब like in Hiranandani hospital where I go, we have a lactation nurse. She is there for 12 hours. So कैसा होता है, obviously in the middle of the night, but then still the other nurses are trained. So they are given this responsibility कि कुछ भी हो जाए, as soon as the baby is delivered and once the pediatrician sees the baby, then you have to pick up the baby and put the baby to the breast. The mother doesn't get shifted outside the labor room till the initiation happens. That's a rule. So we can train our staff, because I understand that we all are busy in our practices. We have 100 other things to look after. Family hai, ye hai. You know, you have to go to another hospital. So in that, if you have a dedicated staff who does this, or you train your senior nurse or probably attendant also, कुछ नहीं करना है, खाली बच्चे को पकड़ के रखना है. And I feel वो भी नहीं possible है ना, तो you train the relative of the patient. That's what I do most of the times. अच्छा, the husband or the mother or the whoever is the best attendant with the patient, you tell that patient only कि आप बच्चे को please यहाँ पे पकड़ोगे क्या, and they happily do it. They love to do it. Picture लेते हैं, you know, they feel very happy about it. So this support is something which we need to change in our setup, where we are allowing a breastfeeding friendly labor room, where it is a mother friendly labor room and a baby friendly labor room. Okay, so I think it all starts from there. And then if the baby doesn't latch, then it becomes the lactation consultant's role that, does the mother have inverted nipples or maybe flat nipples? Yeah, baby has probably a restriction in the movement of the tongue, or the baby has a tongue tie. So all these are later things. But I have seen that even babies who have restrictions in the mouth, or if a mother has inverted or flat nipples, if initiation has been done, okay, I see the babies latch very beautifully. Within the I feel that comparison कि अगर वो कर दिया तो half of the problems are going to be completely solved. And believe me, that is the best pain relief which you can give to the mother, because she feels so happy that I have done this. You are telling her that that's the first vaccination of your child. Okay, rather than before any other vaccination being given. Now, in most of the hospitals, also what happens is कि vitamin K देना है, बच्चे को नहलाना है. I think most of the time moshes are ready with the tub bath and they are like कि चलो हमको ये अभी टब बच्चे को नहलाना है तो गर्म पानी में बच्चे को डाल देते हैं, या तो they want to weigh the baby, they want to give different things to the baby. So I feel all this can wait. What cannot wait is the breastfeeding. So here we need to form that protocol that the mother knows, and we all know, your staff knows, everybody knows that this is a BFHI friendly hospital. Okay, I'm not saying we definitely should take a certification, but even if we are not doing a certification, we have to follow the right breastfeeding practices. So empowering a mother to tell and fight for the right is something which we all need to do. That we tell her only to decide what is right for her baby and what is wrong for her baby, and tell her that initiation has to be done and breast crawl should be practiced. I, in my last 15 years of practice, must have done more than 10,000 breast crawls. Every delivery which I go, okay, my staff everywhere, they know that the baby is going to. So if in a case of a cesarean section, obviously you can't keep the baby on the mother's abdomen and you can't make the baby crawl, but at least we do initiation. So in a C-section also, till when the uterus is still being stitched, okay, I check the baby in maximum it takes 10 minutes to examine the baby. And by that time, the baby is also hemodynamically settling down. The breathing is settling down. The baby's temperature is coming to a normal temperature, what the baby should be. The mother's chest is the best warmer. So if you don't have a warmer in your setup also, you don't have to worry. You have to just pick up the baby and put the baby on the mother's chest. And the baby just latches on and the baby gets the warmth of the mother. And if you want, then you can cover the baby and the mother together with a blanket in case you think that the operation theater is going to be very, very cold. Because inside the utero, the temperature is very high. And obviously, when you bring your baby out in the air condition, the baby doesn't adjust. Okay, so here I feel that it is obviously a joint responsibility, but educating the mothers is the first thing which I want all of us to incorporate in our practices. And, with these kind of lives or with these kind of videos, to tell the mother that why initiation is important and why to put the baby within the first 1 hour of rest. So I'm sure that, in the last two NFHS statistics, we have stayed from 41 to 41 only. We have not changed. But we have not gone little higher also. So this can get higher and we can have more successful rates of exclusive breastfeeding if we do the initiation right. And this can happen if we make a mother-friendly labor room. So I think outside your labor room, everybody should have that written that this is a mother-friendly care, where they are treated with respect, they are treated with love, they're given what they want, and they're given a conducive environment where she can deliver normally. And, I think that feeling of delivering normally is amazing, where that you are giving birth without cutting the mother's uterus. And I'm sure all of you all are friendly in that way, that we don't want to use instruments. We don't want to unnecessarily get into operative stuff when you know that you can have a baby who delivers normally. So I think it's a joint responsibility of all of us to educate the couple, to educate the family. There have been so much of myths about giving pre-lactal feeds, about giving cow's milk, about giving formula milk. We have to somewhere stop that advertising of why formula milk. Like people feel that अच्छा formula milk देने से बच्चे ज़्यादा गोलू पोलू और रोली पोली होते हैं, right? Which is not the truth. We all know that. So I think it's our responsibility to think of the baby first. And I think the obstetricians shouldn't just pass on the baby to the pediatrician कि बच्चा हमारा तो काम हो गया, अभी हमने बच्चा तो आपके हाथ में दे दिया. So I think that is something where breastfeeding should come in the purview that, yes, it is our responsibility and it is a labor room responsibility that the baby should be put to the breast, and not कि चलो 4-5 घंटे के बाद देखेंगे. So that is what I feel is very, very important, Dr. Ritu.
Yeah. Very true, Dr. Jinal. You had given a very brilliant idea for the music and this green tea, lemon tea. That is also very music. Yes, music. Of course, we are doing. Yes, but this giving the some warm drinks is also a very, very good idea. So, Dr. Zinal, now you are the first pediatrician in my show. So now my WhatsApp is full of so many queries, everyone is asking so many questions. Huh? So, with your permission, can I start taking the questions?
Yes, yes,
Yeah.
yes.
So, this question has come all the way from Kanpur. Dr. Anupma is asking, what is the, this is not related to breastfeeding, all the general questions they are asking, what I have done. What is the normal frequency of motions in newborn? And when should we say that it is diarrhea?
So if a baby is exclusively breastfed, the breastfeeding stools are typically yellow in color. They are grainy and they're little frothy and they fall down. They're little loose. So actually newborn baby stools are not hard like adult stools. They're very loose. So if a baby passes loose stools but not watery, it is normal. Now the frequency of the stool can be either they don't pass at all for 7 days, or they will pass multiple times in one day also. So that multiple times can be 10, 12 also. Because some babies, the intestines peristalsis is not that great. So they will pass little. So that is not called diarrhea. Diarrhea in newborn is when the motions are extremely watery, when they are very foul smelling, and the baby is very uncomfortable. Otherwise, it is not called diarrhea.
Thank you. Other question. So many questions they have sent. Huh? At what serum bilirubin baby should be shifted to phototherapy, and at what level we can withdraw it?
Okay, so that's a very relevant question.
Yeah.
But there can't be a generalized answer to this because the level of bilirubin depends on multiple factors. Most important, the day of the life. So we have a chart which we follow. So most of the hospitals have a chart. So if you don't have that chart, you should take a printout and keep in your hospital. So we all have a chart which we follow, that what should be the level on what day of life. And also the bilirubin depends on the cutoff depends on the weight of the baby, and it depends on any condition if the baby has. So on an average, if a baby is G6PD deficient, if there is a blood group discrepancy, if there is a RH incompatibility, if it's a preterm baby, if the baby has thyroid, so that if these are the conditions, then the cutoffs are different. But if you talk of a normal baby, normal full-term baby, assuming that the baby is 3 kgs, then the cutoff or averagely is around 14 to 15. So above 14 to 15, we give phototherapy. And once the levels go down below 12, okay, we try and wane off the phototherapy. Now, I'm personally of the opinion that if you give good sunlight from day 2, and if you do good breastfeeding from day 1, the chances of baby getting high bilirubin levels reaching to the level of getting phototherapy are very minimum. So the babies who are on formula, they go more on phototherapy, and the babies who are on breastfeed go less on phototherapy. And the sunlight exposure is very important, which most of the hospitals and pediatricians don't say. So I think giving natural sunlight is the best killer of the serum bilirubin levels.
Thank you so much. Because these are some questions what we all gynacs are having. So these are some questions.
Absolutely.
Yeah. The other question is, I received the Dr. Mohar has joined all the way from Patna. His question: should we give oxygen and antibiotics in all the meconium stain deliveries, even if the cry is good?
Honestly, no, sir, we are not supposed to give. So if the baby is crying well, if the respiratory rate is good, if the baby is not having tachypnea, there is no need of oxygen. Okay. Now, there are saturation monitors which we all use, and we understand whether the baby is maintaining the SpO2 or not maintaining. But maintaining in a meconium baby also, making the baby hemodynamically stable by warming the baby, making the baby cry, that is very important. Now, oxygen is only decided depending on the tachypnea, the respiratory distress, and the respiratory rate. Second thing, antibiotics, no, sir, it is an absolute contraindication. All meconium babies should not be given antibiotics. Now, how will you decide whether an antibiotic is required or not? Unfortunately, I have seen majority of the obstetricians and pediatricians feel, acha, safe side pe de do. Matlab, half of the times antibiotics are given just to cover. Matlab, it's like an umbrella ki acha kuch hona nahi chahiye bacche ko, iske liye hum de dete hain. But the protocol says that after 6 hours of birth, you are supposed to do a CBC and CRP. Now, if the CRP levels are high, then you start antibiotics. Otherwise, you don't start antibiotics. Ideally, you should be doing a CRP for every baby after 6 hours of birth, and then decide whether antibiotic is required or not. But never use it as a blind protocol. Never.
Thank you so much. Now this other question, Dr. Varna has joined from Mathura. Her question is, what treatment should we prescribe in the babies with eye discharge? And this is very common complaint.
So in a vaginal delivery, most of the times we all know that a mother's vagina harbors staphylococcus. So during the process of delivery, the baby's eyes also catches the staph. And on day 2 or day 3, you might see yellow sticky discharge which is coming in. So ideally, it is the staph which is coming from the mother's vagina. Now, some doctors prefer to take a swab and send it to the laboratory and check it. But I don't prefer to do that unless and until the baby's eyes are red and it looks that the eye is infected. So if it is only a eye discharge, using any good tobramycin eye drops helps. So that is like most of the time we keep it handy and we tell that अच्छा डाल दो tobramycin eye drops and वो discharge 3-4 दिन में चला जाता है.
Okay, thank you. See, now they all motivated. Now everybody is asking all the queries what we are having in our day-to-day practice. Huh? So now this question is from Dr. Shushila. She is joined from Raipur. Her question.
Wow.
Madam, can you please guide us that what we advise the babies with red rashes all over the body, which is also commonly seen in 2nd or 3rd day of the birth?
So any rash, okay, so there is a difference between redness of the skin and rash. All newborn babies' skin is very sensitive, and because they are, just born, they are still acclimatizing to the air and to the environment. They do develop some kind of a redness. So that redness is normal. Okay, it keeps coming and keeps going, and it disappears on its own. Unless and until it looks like blood red to you or it looks infected, you don't need to treat it. But also what we need to be very, very careful is what products are we using on the baby's skin. Because in most of the smaller cities, they use a lot of sarson ka tel, lal tel and all those kind of stuff. So probably when massage is started early, the baby has a tendency to get more oil dermatitis. So please start massage only after the umbilical cord has fallen off. Do not start giving the baby bath and massage before the umbilical cord falls. The umbilical cord falls anywhere between day 7 to day 14. So we do not advise to do massage or apply anything on the baby's skin. Just sponge the baby. And even in sponge, there is no need to use any cologne water or soap or anything because the baby's skin is very, very sensitive to any irritants. So don't use any strong smells. That's why you see most of the baby products have no smell. They're very neutral, soft things. So you should avoid any application on the baby's skin. No betadine also, no neosporin, kuch nahi chahiye. Okay. And the rash is usually called malaria and it disappears on its own.
Yeah. Thank you so much.
Yeah.
Now, receive this question from Dr. Patil from Satara. Madam, Madam, in the same context, this question, what do you advise for the dry skin in babies and for the scaling on the scalp?
So scaling on the scalp is called, I'll take the second part question first. The scaling of the scalp is called cradle cap. Okay, it is mostly seborrheic dermatitis. It happens in babies because after they are born, the skin of the scalp becomes dead and it becomes completely dead skin. So that dead skin dries off and it forms a thick layer. And it looks like as if topi pehna diya hai. That's why it is called a cradle cap. Now, cradle cap is normal for newborns. There is nothing to worry about it. Honestly, when you just scrub the dead skin, just how you scrub sometimes using a scrub, it disappears. But there are some applicants available in case agar bahut zyada hai. So you can use any cradle cap applicants to remove it. So even oil can be used, or there's something called as Etogla, which is available, which we very commonly use. Etogla lotion. You apply it on the scalp and all the seborrheic dermatitis comes out. So that is about the cradle cap. Now, second thing, yes, I do advise in my practice using moisturizer because baby skin becomes very dry and we all like baby skin to be nice and soft. So they can either use oil as a moisturizer if you are using 100% pure oils, but if you are using packeted oils, then I prefer using baby specific products only. मतलब जो चीज जिसके लिए बनी है उसी के लिए use करनी चाहिए. So there are a lot of baby products which are available, which are as I said neutral, and they maintain the skin pH. So maintaining the pH of the baby to 5.5 is very important. Because if you use products like Dettol soap, yeah, Savlon soap, yeah, maybe you know that any other soap which have very strong this thing, the skin becomes very, very damaged. It becomes more dry, it becomes scaly, and then it becomes more prone to infection. So use only baby specified moisturizer and baby specified bath products, whatever you want to use. But yes, I do advise using moisturizer 2 times a day to the baby.
Thank you so much, Dr. Jinal.
Yeah.
Dr. Jinal, I am getting a bombardment of the questions. See, this question is from Dr. Harmeet Kaur. She's joined from Ludhiana. Her question is, how oral hygiene of babies to be maintained? Madam, please enlighten us.
So there is no need to clean the tongue of the baby. There is no need. I'm talking of newborn babies here, okay? I'm not talking of bigger babies. There is no need to clean the tongue because there's another belief system कि बच्चे की जीभ साफ करनी चाहिए. So what majority people do is they'll take some kapda, malmal ka kapda or something, and they will wet it and they will, thrust their finger inside the baby's mouth and clean it. No, not required. So babies have good bacteria in their mouth, okay? We don't want to wipe them off. And by we putting a finger or we using any oil or using any cloth, we are actually contaminating the baby's mouth and we are putting harmful bacteria inside. So actually we are causing more infection to the baby rather than causing any good. So there is no need to take care of the oral hygiene at all. Like even at times what mothers feel is कि अच्छा थोड़ा दूध रह जाता है ना मुंह में तो मैं कैसे साफ करूँ. ऐसे साफ करने की जरूरत नहीं है. अपने आप the milk will go inside the baby's stomach, and the milk, the breast milk contains that kind of a anti-infective property that it doesn't let that get infected.
Okay, thank you so much.
Yeah.
There is one question from Dr. Sheikh. Only Dr. Sheikh is written. Dr. Sheikh joined from Pahalgaon, Jammu Kashmir.
Wow.
Yeah. The question, I am also not aware whether he or she. The question is, sometimes even after shedding of cord, there is persistent discharge or wet cord stump in spite of local antibacterial powders. What to do, ma'am?
So usually the umbilical cord falls off between day 7 to day 14, right? Now after 7th day, suppose if the cord fell off, the cord doesn't dry. The cord takes longer to dry. The cord dries anywhere after around between 14 to 21 days. So please wait till 21 days for the cord to completely dry and that pus and that sticky discharge to stop. It will stop automatically on its own. Now, the only thing what you have to keep a watch on is the stump foul smelling. So when you see any discharge, because discharge is normal, but when you see any discharge, you just go a little close and take a smell. If you feel that there's a dirty smell, then probably it is infected. Then you need to treat it. Then probably you need to collect the swab, send it that what kind of a bug is it, and then you need to treat the baby with antibiotics or any antibacterial local applicant like T-Bact or anything can be used. But 99% of the times, the discharge settles on its own by day 21. Now, if by day 21 it doesn't settle, then probably you need to go and cross-check whether vitamin K was given right to the child or no. Because sometimes if vitamin K is not given, then the cord takes long time to dry off. So then you can repeat a dose of vitamin K.
Very, very nice tip. Yeah, thank you so much, Dr. Jinal. Dr. Jinal, now I'm taking one more question. This is from, this is Dr. Meghna Jha. Meghna Jha is joined from Motihari, Bihar. She is writing, is it necessary that after meconium-like a delivery to give gastric lavage of the baby for 3 days or so?
No, it is not necessary at all. So gastric lavage, now we don't advise too much unless and until we feel that the baby has aspirated too much of a meconium. Now, if the baby has aspirated meconium, which is visibly noticed by the obstetrician, then only one gastric lavage has to be given before the feed is to given to the baby. Not for 3 days. Not recommended at all.
Thank you so much, Dr. Jinal. Still the question, some are repeated, so I'm not taking. So thank you once again from the bottom of my heart for sparing your time.
Absolutely.
So now, Dr. Jinal, we have completed the one round of my session, the icons in conversation with Dr. Ritu. Now we are coming to a non-academic portion.
Okay.
So here I'm going to ask you some non-academic questions, which you have to answer in one word without taking much time.
Okay, like a rapid fire round.
Yes, it's a rapid fire round.
Okay.
So, yeah.
Great.
Your favorite color?
Pardon?
Your favorite color?
My favorite color, white.
Okay. Your favorite fruit?
Strawberries.
Wow. What motivated you to become a doctor and especially a pediatrician?
So I feel that honestly, I wanted to always become a doctor from the time I was in my 5th standard. I'm the only doctor in my family. And I belong to a very conservative Gujarati family where my parents are not educated. So I, from the beginning, always thought that I want to become a doctor because I have that healing power in my hand. And that everybody still tell me that you have magic in your hands. So that
Wow.
motivated me to become a doctor. Honestly, I wanted to become a surgeon, and that was my dream. But fortunately, unfortunately, I couldn't complete that. But I'm very happy now to be a pediatrician because I love babies, and I think I get more happiness treating babies.
Great, great, great. So you were a coffee person or tea lover?
Honestly, I was a tea lover, but these days I'm obsessed with black coffees.
Okay. Okay. So chocolate or vanilla?
Chocolate.
Okay, great. So, Dr. Jinal, do you want to give some message for the upcoming pediatricians and especially those who are want to become a lactation consultants also? So please give some expert advice. So that will be
So,
for the upcoming doctors. Yeah.
so I feel that we all doctors need to educate ourselves. Education never ends. Just because we have studied for 10, 11 years during our study curriculum doesn't mean कि सब खत्म हो गया. So my biggest message to everybody is that whether you want to specialize into lactation, whether you want to specialize into infertility, whether you want to specialize into something adult, or you want to specialize into adolescence, something, but keep reading. Don't let the student in you and don't let the learner in you die, because the moment that happens, that you get stagnancy in your practice, and when there is stagnancy in practice, you start getting outdated. So I feel the biggest message for everybody is that however you want to learn, you want to learn with other people, go for conferences, do online things. Now everything has become so easy online. Wherever in the world we are, we can talk to each other. So you have to keep educating yourselves, and when you educate, you are here and you will never go outdated.
True, true, true. That's a very, very good message. Yes, of course, the knowledge always increases by sharing. My aim of doing these programs, and I'm running so many academic groups also, only for this, that the problem what we have suffered that time, the net was not so. Now this is a very good time and lot of discussions we can have. So
Absolutely.
thank you once again for a wonderful session.
Thank you.
Over to you, Dr. Nishant. Dr. Nishant, is it any question in the chat box, as I am not able to see from the mobile? I have taken also
And
YouTube.
only one question was there. What are the signs of ineffective suckling?
Okay, so there's a very good question, and I think this is related to my breastfeeding. So I will just, Dr. Ritu, take it quickly in a minute. So when a baby suckles, what happens is, like, suppose if this is the breast and this is the baby's mouth, when the baby suckles, okay, what happens is the baby uses the palate and the tongue to put pressure on the areola, and there is negative suction formation in the back of the mouth. So now the milk flows from the breast because of the suction which has formed. That is why if you see a latch, in a good latch, you can't easily withdraw the latch because the baby has held it so tight because of the suction that here the milk transfer is effectively happening. Now, if the latch is inadequate, what happens is the suction will break very easily. So it will not be a sustained latch. Second, the baby keeps going off to sleep. The baby doesn't effectively do that. And third, if we are drinking water, now if I'm drinking water, we will see that there is a swallowing movement over here. So you can see that apne chin ke area se you can see the baby swallow. So if this is the baby's chin, okay, you should see the suck pauses, which is like baby pee raha hai na, to ye hai na zyada upar niche hona chahiye. And if the baby is not drinking milk, if the baby is only holding the breast in the mouth, then ye itna hi move hota hai, like as if you are eating a chewing gum. But if the baby is drinking, it will go down, it will go down, it will go down. So you actually can sometimes hear the gulping also, and you can see the swallowing. So that is how we as doctors can analyze whether the baby is drinking or whether the baby is time passing.
Thank you.
One more question is there, that how can we know that the baby is overfed during suckling, which may also lead to constriction and breathing of the baby? Like,
Okay. So honestly, according to me, babies never overfeed. Okay, on the breast. So if they are done, if the stomach is full, they'll either go to sleep or they will release the breast. Okay, so 80 to 90% of the times babies are never overfed on the breast, unless and until the mother has oversupply, which is too much, and the baby is getting choked because, like,
yeah.
that because of oversupply, if the baby is getting overwhelmed with too much of milk coming into the mouth, that the baby can't handle. So in that scenario, what you need to do is you need to do laid back nursing. So what I mean by laid back nursing is, like, if this is my baby, the mother should go behind like this, and the baby should be kind of completely straight. So the baby is drinking straight and not sleeping. This is not the baby. This is the baby. Okay. So then the babies don't get choked. Second, what you can do is you can do blocked feeding. So a normal breast contains anywhere between 8 to 12 ducts. So you can just obstruct 1 or 2 ducts with your thumb and the index finger. So the flow of milk into the baby's mouth reduces. So you are blocking 2 ducts. Third thing, what you can do is you can ask the mother to pump it out either using a breast pump or hand to express some milk and then feed the baby. So then the baby is not overwhelmed with too much of supply.
Thank you so much for giving these answers. I think this was the 2 questions that we received in the chat box.
Okay, great. Awesome.
Thank you, ma'am.
So we
It was
will
very nice and crisp session.
Yeah. Thank you for enlightening all of us.
Welcome, madam.
We are really grateful to you. So friends, with this, we will wind up for today. So thank you, Nishan. Thank you, Sahiti. Thank you, Shil Pharma, for providing the platform. So stay tuned. We will meet soon again on next Thursday, same time, 8:30 p.m. Indian Standard Time. Till then, bye-bye.
Thank you, ma'am. Thank you,
Thank you
Dr.
very
Sinha.
much.